The most valuable tool an EMT can possess is excellent patient assessment skills. While there are differences between how we assess medical and trauma patients, the initial approach is largely the same. Take standard precautions for body substance isolation based on what you know of the call. Gloves and goggles are a minimum for every call, but you may need a gown for massive bleeding or face mask if airway management is going to be required. The scene size-up actually begins with your dispatch information. What you are told about the location of the call and complaint can give you information about what to expect when you arrive. For example, if you are responding to a martial arts studio, you might expect a fall or musculoskeletal injury. Upon arrival, ensure the situation is safe to enter, meaning that there are no hazards to the safety of you or your crew, such as a loose dog, poor lighting, or a fight in progress. Determine the number of patients who will need your attention and whether or not additional resources, such as ALS responders, law enforcement, hazmat, or the power company will be required. Call for help now if additional resources are needed. Once the scene is secure and additional help has been called if needed, determine the mechanism of injury based on the patient's chief complaint and initial presentation. Or, if the patient is unconscious, bystanders or scene clues such as an overturned ladder or vehicle deformity may give you important information. If the patient has been involved in any type of fall or blunt force trauma, or presents to you on the ground without explanation, begin manual immobilization of the spine now until you are able to confirm that a spinal injury is unlikely. Your primary assessment should be done the same way every time on every patient. The purpose of the primary is to find and correct life threats such as apnea or hemorrhage. Having a consistent approach to the primary assessment will ensure that you identify the most pressing, life-threatening issues with your patients every time. The primary assessment begins when you determine your general impression of the patient. This is often stated as a level of distress, such as mild, moderate, or severe, sick or not sick, or as an obvious injury, such as head trauma or a suspected leg fracture when deformity is readily apparent. Next, determine the patient's level of consciousness. Discover whether they are alert when you come in, meaning they are aware of your presence. If they do not seem aware that you have arrived and are presenting with their eyes closed, attempt to gain their attention by using loud verbal stimuli and, if unsuccessful, appropriate painful stimuli such as interdigital pressure. If they do not open their eyes or speak to the verbal or painful stimuli, they are said to be unresponsive. Regardless of level of responsiveness, introduce yourself and attempt to gain consent to treat the patient. Of course, you may treat an unconscious patient using implied consent. If the patient is alert, ask them for their chief complaint or the main reason you were called. In the event of an unresponsive patient, you may be able to determine the problem from bystanders or the scene itself. Your assessment of the airway is next. You will need to confirm that the airway is patent, and if not, open it now using a jaw thrust technique to avoid compromise of the cervical spine. Look inside the airway to make sure that there are no obstructions or substances that need to be suctioned. If suctioning is required, clear the airway now. In a situation where it appears that the patient is unable to maintain a patent airway, such as in a patient with an altered level of consciousness, insert an OPA or NPA now. Assessment of breathing comes next, including respiratory rate, rhythm, and quality. You will also need to determine if the patient has adequate tidal volume. To begin this assessment, you should bare the chest to check for any wounds or bleeding. If an open chest wound is apparent, an occlusive dressing should be applied. Also look for medical alert tags. It is not uncommon that a medical emergency precedes a traumatic event. A bare chest will also help you to listen to lung sounds without interference from clothing. In addition to auscultation and inspection of the chest, you will need to palpate the chest wall for stability and to ensure that the patient doesn't have subcutaneous emphysema, crepitus, or pain on palpation. Oxygen should be applied now if it is indicated. For respiratory rates less than 10 or greater than 28 to 30, or for inadequate tidal volume, Ventilation should be assisted using the bag valve mask attached to 100% oxygen. The radial or carotid pulse can be used to assess circulation of a trauma patient. If a radial pulse is not present due to poor perfusion, move to the carotid pulse. Check for pulse rate, rhythm, and quality. Assess the skin for color, temperature, and moisture. Another way to assess for distal perfusion is by checking capillary refill time by putting pressure on the nail bed and counting the number of seconds for blood to return to the area after it is blanched. Normal capillary refill time is less than 2 seconds, indicating adequate distal perfusion to the extremities. Control any major bleeding if present and possible. You can begin to control external hemorrhage with direct pressure. In some situations, a patient will present with internal bleeding. Internal bleeding from, say, a liver laceration or damaged kidney obviously cannot be controlled by EMTs. Therefore, you will need to begin treatment for shock, which includes lying the patient flat and covering him or her with a blanket to preserve body heat. While you already determined level of responsiveness using the AVPU scale, it is now time to determine level of orientation using the patient's answers to questions about their name, time of day, current location, and events leading up to the EMTs being called. This is called alert and oriented times 1, 2, 3, or 4, depending on how many questions about person, place, time, and event they answered correctly. You could also use a Glasgow Coma Score to report level of consciousness in trauma patients. Now is the time to assess pupil size and reactivity to light as another measure of neurological activity or disability. In some situations, a patient will present with major trauma. Major trauma patients need to be fully exposed, with their clothes cut off or otherwise removed. An isolated injury, such as an ankle fracture, could have just the area involved exposed. Based on the information gathered in the primary assessment, identify and treat any life-threatening conditions. Any insult to airway, breathing, or circulation, or neurological disability, including altered mental status, indicates a critical patient. If the patient does have life-threatening conditions, begin packaging and transport now. In a situation where no life-threatening conditions exist, you will likely stay on scene for a while to gather more information, take vital signs, splint injuries, and treat for pain. While vital signs are actually the first part of the secondary survey, it is unlikely that you will take these yourself as you will be busy talking to the patient. It is appropriate to delegate vital signs to a partner so that the information can be gathered simultaneously during your history taking. Note that in the critical trauma patient, the history, secondary assessment, and reassessment are all performed en route to the trauma center. First, gather a history of present illness by asking the patient what happened today to make them call EMS. The mnemonic OPQRST can help explore a complaint of pain. O stands for onset. You would ask what the patient was doing when the pain started or what caused it. P stands for provocation and palliation, meaning what makes it feel better or worse. Q stands for the quality of pain. To assess quality, you will ask the patient to describe what the pain feels like. They should give you an answer such as sharp, tearing, or pressure. R stands for region and radiation, meaning where it hurts and if that pain moves anywhere, such as the neck, jaw, back, or shoulder. S stands for severity and should be rated on a scale of 1 to 10. T stands for time or timing, meaning when the pain started and whether it is constant or comes and goes. Next, get a sample history to include signs and symptoms, any allergies the patient has to medication, food, or the environment, any medications the patient is taking or supposed to be taking, including any recently started or stopped, any herbal or over-the-counter preparations, pertinent past medical history, last oral intake, which is especially important when treating possible diabetic or allergic patients involved in trauma, and events leading up to the present illness. Once you have finished the history gathering, check in on the vital signs you have delegated or take them yourself now if necessary. You will want to know about the patient's pulse, respirations, skin signs, pupils, and blood pressure. You can gather other diagnostics now if you have them available to you, such as pulse oximetry and blood glucose monitoring. The body system to be examined first should be related to the chief complaint. For example, if you are treating a simple musculoskeletal injury, it may only be necessary to examine the injured extremity. In an alternate situation, where the patient is unconscious and cannot relay to you the chief complaint or mechanism of injury, then it is appropriate to do a head-to-toe assessment which begins naturally with the head. Use the tools of inspection, palpation, and auscultation to find any abnormalities that might be contributing to the patient's condition. When assessing the head, check for skull fractures, bleeding, stability of the orbits, blood or fluid in the nose or ears, or loose teeth. Check the neck, both front and back, for tenderness when the spinal vertebrae are palpated, heat or warmth which could indicate a fracture, jugular vein distension, or tracheal deviation. Although you have already examined the chest once, it is not inappropriate to go back and reassess the chest now for paradoxical movement, stability, or signs of increased work of breathing. Check all 4 quadrants of the abdomen for tenderness, rigidity, masses, bruising, or bleeding. Push anterior to posterior and laterally on the pelvic wings to test for stability, pain, or crepitus. Do not rock the pelvis. Check all 4 extremities for wounds, stability, and distal circulation, sensation, and movement, often referred to as PMS. Don't forget to check the posterior of the body for bleeding or other injuries. Decide what you think is likely the problem, called your field impression, and inform the patient and your team of the treatment plan. As soon as time permits, usually every 5 minutes for unstable patients and every 15 minutes for stable patients, reassess your patient. Since scene time is kept minimal in trauma patients, reassessment will most likely be performed in the ambulance en route to the trauma center. You will repeat your initial assessment, or ABCDs, including the chief complaint. Now that you have more information, determine if the chief complaint has changed or the condition worsened. Take another set of vital signs. It is your goal to get serial vital signs, or at least 3 sets prior to the transfer of care. Serial vital signs allow you to trend the patient's condition as it gets better or worse. Evaluate the patient's response to your treatments. For example, if you splinted an extremity, check to see that continued swelling has not caused the splint to become too tight. If anything has changed or no longer seems helpful to the patient's condition, revise your treatment plan now and take appropriate corrective action, such as changing to onboard oxygen if the portable tank has run out. Either during a radio report or upon arrival to the emergency department or other facility, introduce yourself and the patient and give a full report about the patient's mechanism of injury, chief complaint, presenting problem, history of present illness, past medical history, vital signs and physical exam findings, treatments, and response to those treatments. Document all of the above, including any observations about the scene, on the patient care report.